Good afternoon, all. I am Guru Swami from Wipro GE Healthcare. We, GE Healthcare, thank you all for taking time today to attend this lunch symposium. As we all knew, liver-related problems like non-alcoholic fatty liver disease, NASH, are the biggest burden across the globe as well as India. The need of the hour is it's an effective tool which can diagnose the liver disease early for a timely treatment. I am really excited to invite Dr. Chander Lulla sir for today's unique session. Dr. Chander Lulla sir is a well-renowned radiologist both nationally and globally. Sir comes with more than 2 decades of experience in the ultrasound industry. More than a decade, one of the key focus area of Dr. Lulla is liver imaging. Today, sir will be talking to us about the advancement in liver diagnosis.
We have 2D shear wave, what we have been calling different things, RFE, shear wave, fibroscan, etc. And UGAP, which is the new thing, which is very exciting. Contrast, but I'm not going to talk on contrast because we're trying to focus on this because contrast is a whole subject by itself, unless you have more time for that, but I'm sure there are other things to listen to. So we've always had this sequence of events from ultrasound, color Doppler, ultrasound, and contrast enhanced we've been doing from last 10 years. What we were missing was tissue stiffness and tissue elasticity, and the changes in tissue behavior we were missing. So that's been added with ultrasound, and that's really very exciting and can be used for everything. I see Ankit, a musculoskeletal person here, sitting and gorging on his, you're going to get fatty liver on his sandwich there. So that's the problem that we all land up with. Do you have fatty liver? Because that's the crux of the problem. And we know that this can be secondary to a lot of conditions. In fact, nowadays when we started doing this UGAP and a lot of patients coming in, most of them are actually not alcoholics. So they're not really alcoholic. Obesity is a bigger problem, as you know, in our country compared to ethanol. So a lot of faulty diet which leads to obesity and what we call as non-alcoholic fatty liver disease. And this is growing tremendously worldwide, especially in this last 2 years. We've seen that patients, a lot of people have stayed at home, no exercise, and everybody's put on weight, 5-6 kgs, except I think Anirudh is lost weight. So most of us have put on weight. And in many underlying comorbidities, as you can see, we have a huge population of hepatitis C and B in our country. So steatosis is associated with more severe fibrosis and rapid disease progression. And almost all hospitals are now doing liver transplant. It's become like renal transplants. And so the presence of steatosis impairs the regenerative capacity of both the donor and the recipient. And you can see that this is tremendously increasing with our type of diet. Now, this is a very important slide because this is really what we are trying to do. We are trying to bridge this gap here. So we have non-alcoholic fatty liver disease or even alcoholic liver disease for that matter. But this is just steatosis or fat deposition without liver injury or liver inflammation. And when it moves on to what we call as NASH, that is non-alcoholic steatohepatitis, it's really when the inflammation starts, there's steatosis causing inflammation, and that has the potential to progress to chronic liver disease. And this is what we are trying to avoid here and try to help our patients with. So in the past, of course, as with all these modalities, liver biopsy was the only answer. And I don't think we do as many liver biopsies. I think last 20 years, we probably do 1 in 3 months or something like that. The incidence of liver biopsy has really gone down. Now, this is also another important thing. After COVID, we've seen a lot of young people getting cardiovascular disease, sudden deaths, sudden myocardial ischemia. And there is some association of liver fat with the cardiovascular situation. There are many times where we identify disease. It's just like on the fetus, we see a rhabdomyoma and then we find out the parents have tuberous sclerosis, that they've got diabetes. The first point of action actually is ultrasound, where you find there's fatty liver and you tell the patient, and then he goes and does all the tests and finds out that he's got diabetes, hypertension, hypertriglyceridemia, and high density lipoprotein is high. So the steatosis is what we are trying to look for. 10 to 20% of them will progress to NASH, 25% will progress to fibrosis, and about 2 to 5% will move to cirrhosis and hepatocellular carcinoma. So that's what we are targeting, and with this new technology, at this stage, we want to prevent steatosis converting to NASH. Then with shear wave, we want to see whether NASH is really causing potential problem of fibrosis. Is it going to be reversible or not? And we have seen in the past 2 years, 1.5 years that I've been using this technology, now we have a huge database of people coming again and again, 3 months, 6 months. And what I realized after telling them for so many years that you've got fatty liver, didn't really work. But now when we're giving them figures that you've got this much percentage of fat and this much is your fibrosis, it really impacts on them. So they kind of act on that data, and they are coming back after doing, we've had patients who've really lost, I had a patient who lost 40 kgs of weight in 6 months and came back. A patient was severely diabetic on insulin, was cirrhotic, father died of cirrhosis, and had hypertension and was on multiple drugs. 6 months later, after losing 40 kgs weight, no insulin, no blood pressure. I mean, I unfortunately couldn't put the pictures on the computer, but he looks completely different. And the cirrhosis has reversed to mild fibrosis. So something unheard of. We thought that these were end-stage diseases. He didn't have a small liver. He didn't have like nodular liver. He had an enlarged fatty liver, but the fibroscan score was in the range of cirrhosis. So he already had chronic liver disease. And today, when we repeated after 6 months, he's got mild fibrosis. So when he actually saw those figures changing, the man was very ecstatic because he put in a lot of effort with diet counseling, exercise, and in 6 months, he showed wonders. So it is possible to reverse all these conditions. So it has been seen that improvement with 5% weight loss, we are seeing improvement in liver fat. With 7 to 10%, we are seeing improvement in the NASH score. And more than 10% is seeing improvement in the fibrosis stage. So just about 5 to 10% weight loss, we are seeing such excellent change. Of course, ultrasonography has been good in terms of telling us echogenicity, echo texture, liver surface very well. So of course, you've got a small nodular liver, that is really bad. But at other times, we need proper classification, and we have a lot of inter-observer variation. Somebody increases the gain and calls it fatty liver, somebody decreases the gain, and this thing goes on and on and on. Somebody comes and tells you, oh, but my previous guy told me I've got grade 1 fatty liver, and you're telling me I've got grade 2. So, and I've just done it yesterday. And somebody told me I've got grade 3, so I've come to you, and then we say it's grade 1. So it goes both ways. So we, of course, look at the periportal fat, look at the diaphragm, look at the kidneys, and we call it grade 1, grade 2, grade 3, dependent on whether it is the periportal fat is seen or the diaphragm is not seen. So that's normal, that's grade 1, and that's grade 2 here. This is grade 3, almost the diaphragm is disappearing. So these are the different grades. Now, ultrasound is very good for moderate to severe fatty liver. So we have a sensitivity and specificity almost more than 80%. But for mild and moderate disease, where the fat content is less than 20%, the sensitivity is as low as 60 to 65%. And that's really what we also want to target, because the moment they have more than 15-20% fat, we need to target that. And then there's a lot of inter-observer variability. As I said, there are almost 70% inter-observer variability. What somebody thinks as, well, and in today's time, I mean, this is really a huge figure because you want objective criteria. So that is where ultrasound UGAP comes in. And that's you'll just see in a minute. Oh, I forgot. They told me, do you have sound? I didn't realize there's no sound on this, but I'll probably. So this is the new Logiq E10, which is very exciting. I used to see all these demos across the world, fat estimation, and always was very keen that when am I going to get it. And 2021, that is December, finally got this technology. And so 1 billion people worldwide have NAFLD. So ultrasound attenuation, that is how much the ultrasound beam is getting absorbed in the liver, what we call it attenuation, is an important criteria for fat estimation today. So they measure the attenuation level and they give us values which tells us what is the attenuation level. So with increasing fat and fibrosis, the attenuation increases, just like with elastography and fibroscan. And needless to say, it's with regular ultrasound, so it's a quick 2-minute test, as I tell my patient that you're coming for a 2-minute test. And one important thing is because we are facing a lot of resistance from hepatologists who have their dedicated fibroscan machine. And only last week in a hospital where I was dealing with the trustee of the hospital, I was strictly told, please do ultrasound, don't do the fibroscan, because the hepatologists have said that ultrasound cannot penetrate thick skin. So only they can do it with fibroscan. So when the physician came with the patient and I showed her that we can do fibroscan and UGAP, she was amazed. She said, but the hepatologist told me that ultrasound beam cannot penetrate thick skin. So this is what they are using as a medium to distract the attention of people. So she was quite amazed. She said, wow, you can see it. And the best part is that you can see the rest of the liver while you're doing the ultrasound, which the fibroscan people just can't do. So it's a blind technique. It's a push pulse transducer like an A-wave used to do in the olden days. Shabir, I think, must have seen that technology. And they don't know what they're hitting. They're hitting things blindly, giving a figure with lovely those brown scores, and everybody believes them because it's a hepatologist and they say that, your score is so and so, and it's absolute rubbish. Because there is no way I will believe a report. I know we all see ultrasound every day. It is sometimes so difficult to see good liver images in the, you have to turn the patient, make the patient do inspiration and everything, all sorts of funny things to get good right lobe liver estimation. So this, of course, we'll show you on the demo very quickly. You target the segment 5, 6, 7 in this area, which is free of blood vessels, just like 2D shear wave or RF, as we used to call it earlier. And in expiration, patients should be fasting for at least 4 hours. And we avoid blood vessels. We keep the arm extended so that the intercostal space is widened. You can do it in supine or left lateral decubitous. And we keep the ROI in an area where there is no blood vessel, there is no mass. And I actually did a patient on a demo where we were doing a demo and we found a big liver mass. And imagine when you're doing a blind technique that you're going to get measurements on the mass and things like that. So there were granulomas, there's calcification, there's so many things. And then the technique, of course, will show you. And then we get stages of steatosis. So we have a more objective method now. It's called steatosis stage 1, SO 1, 2, 3. And these are the graphs, plot graphs, box plots, which tell you in decibels per centimeter per megahertz, what is the level of steatosis. So as the attenuation increases, your steatosis grade increases. Obviously, stage S2, S3 is more than 60% fat in the liver. So this is something that I have made on the basis of my last 1 year's assessment of how things go. So SO is less than 5% fat and the value is 0.49. S1 is 5 to 33%. Anything above 0.65. S2 is 33 to 66, more than 0.7, and S3 and above is 0.77. So fibroscan also has technology. It's called controlled attenuation parameter, which is the same and which tells us in decibels per meter, which can also be done on the UGAP machine. So it's dB per m here, and in the range of 100 to 400. So if you want to compare the results, you can do that also. And it's same technology, but it's a blind technology. So limitation of CAP is insufficient visual guidance, and it can be performed in A mode only. And actually, in fact, you can see changes in attenuation rate with underlying increased body mass index in diabetic patient, and this has been published in data. So what is being a negative point for fibroscan today, the hepatologists are saying is a negative point for ultrasound. So there are a lot of papers now, as I think in 2010 when you heard us talking about fibroscan, everybody said it's a lot of rubbish, a lot of colors you're showing, and there's, but then it's data. You see, it's all published now. So B-mode image-guided ultrasound attenuation detects hepatic steatosis in chronic liver disease, and there's good sensitivity and specificity for looking at the different grades of. So you can see that there is good correlation both with the CAP technology and also with MRI and other technologies. So this has been correlated with MRI, and these are the figures, the same figures which I was talking about, the attenuation cutoff figures, which have a very high specificity when you compare all the technologies. So if you see the area under the curve, which I had just shown you, the accuracy of S2 or higher and is 0.95 and above. So, and at the same level, CAP is 0.84. So we are scoring a little bit more, and that's expected because it's image guided. So with S1, of course, it is 0.9, and with CAP, it is 0.82. So also UGAP has the advantage that it can tell you both chronic liver disease and steatosis at the same time. So it's also been compared with MR proton density fraction, and that also is this is a paper published recently, and it has shown that ultrasound and UGAP is high correlation with the cutoff of 0.62 as the cutoff for the accuracy being 0.9 or higher. So when we talk of all these technologies, ultimately the goal is that it should benefit the patient. So now when you have a patient doesn't come to you saying that tell me whether there's fat or he wants to know everything. How's my liver doing? So he wants to know all the information, that is there steatosis? Is this steatosis causing NASH? That's really the important information. And we have serology, which is non-specific, a lot of false positives and negatives, regular imaging, and of course biopsy. And you can see that today in this world we have so many pathogens which can finally affect the liver. So we have hepatitis B, C, alcohol, of course, and as I call it, McDonaldization of society. So we have about, this is in India, 40 to 50 million carriers of hepatitis B. Hepatitis C, we have about 12 million carriers. And alcohol is increasing. I'm sure this figure must have gone up in the last 2-3 years with the COVID, 7.8 million, and obesity is also on the rise. So we have these different stages of cirrhosis, but what's important is that, as I showed earlier, when we have infection, we land up with chronic hepatitis in as high as 75%, and the same figures, 20% cirrhosis and 2 to 3% hepatocellular carcinoma, and this is potentially reversible. That's the important thing. So progression of fibrosis is dynamic, and regression of fibrosis is possible with treatment in some situations, with lifestyle modification, antiviral therapy in viral hepatitis, and immunosuppression therapy in autoimmune hepatitis. And we've seen results in the last, even, it's always difficult as a radiologist, we're always questioning, does this really work? But from 2010, when we started doing elastography, we've seen patients on steroids improving with immunohepatitis, autoimmune hepatitis, and even now antiviral therapy patients improving. So it's been, and we have a whole big gamut of antiviral therapies now available. You can see in the COVID times, every day there's a new drug coming up. And the same, so HPV infection antiviral therapy has shown histological regression of fibrosis in 91%, and even cirrhosis, like I said, regression in 74% after 5 years of therapy. So this is something that we need to keep note of. That means that these are regressing pathologies. So we need a non-invasive technology, and ultrasound is fitting with all these things because it's quick, it's non-irradiating, it's relatively inexpensive. If you compare, biopsy today costs 15 to 20,000 rupees, and it's integrated to your ultrasound platform. does not require very high training, and usually there is no measurement failure unless you're dealing with really bad liver and the shear wave is going all haywire. But even obesity and ascites is not a limiting factor. I want to repeat this because this is what the hepatologists are saying, that you can't do ultrasound in obese individuals, you can't do ultrasound in patients with ascites. So this is really not the fact of the matter. So of course, what we are now in the third stage of development of shear wave elastography. We've gone through strain, we've gone through shear wave, blind, and now we are in the stage which I call the third stage of development, is 2D shear wave, where you can see the B mode simultaneously and you can do the shear wave simultaneously. So this is a good comparison of where exactly you are imaging and taking the shear wave. You also have a quality control, so which we'll just talk about on the workshop here quickly, where it can tell you that you are having some problem and you should not take a measurement at that level. So this was our very old techniques. We were doing shear wave without 2D shear wave, so I'm not going to go in that. But just to show you that this patient had a very small liver here and a lot of collaterals, and he was labeled as cirrhosis and sent for a liver transplant, believe it or not. When we did a shear wave, it was absolutely normal, and this was extrahepatic portal hypertension. So the liver was normal, and now if you do a fibroscan, what are you going to hit? I mean, there's so little liver there, so it's going to be so tough. So these are, of course, then we did a lot of biopsies. We have established the standards. We've done follow-ups for many of these patients. And we have seen that things have been changing. This is post-steroids. I'll not go through these individual cases. So this is the shear wave map that we have, which I think all people are aware of now. What are the shear wave velocities, both in kilopascals and in meters per second. Generally, we like to use meters per second, but hepatologists like it in kPa, and you can give both values. So generally, if it's less than 1.48, then it's normal. 1.4 to 1.5 is F1. So these are incrementally increasing, F2, F3, and then finally F4 above 1.76. And then there are guidelines of how to manage these cases. So the rule in and rule out. So if the value is less than 1.3, 1.4, it's normal. This is SRU guidelines. And if it's less than 1.7, in absence of clinical signs, it rules out chronic liver disease. And above 1.7 to 2.3 needs further testing. Above 2.1, you rule in and you don't need a biopsy. Above 2.4, this is portal hypertension with cirrhosis. So just few quick cases. So this is a liver. Now you'll probably call it grade 2, grade 3, depending. And so at the same sitting, we do a UGAP and we do elastography. So in a matter of 2 to 4 minutes, you're done with, you get values like these. You get about 8 to 10 values, and then you take the median. And your median, this is the statistical range where you should have a median value of the highest and the lowest. So it's not an average value, it's the middle value. And the way to look at that is that your variation should be less than 15%. So what we call as the IQR to median ratio, here it's 9%, it should be less than 15%. So these are the UGAP values, and you can see that this UGAP value is very high. It's almost 0.80, so almost more than S3 stage steatosis. And the elastography value shear wave is 1.63. So it's like mild fibrosis with severe steatosis, completely reversible. This was another patient, diabetes on glycophage. Glyco was 6.5, angioplasties, etc., cholesterol. This is again the patient's this thing. And I think UGAP was 0.72, so it's about 33 to 67% fat. And shear wave velocity was low, not very high, so mild fibrosis. So at the same sitting, you're telling the patient how much fat you have, is it causing NASH? And they really they get sensitized to it, they act on it, and they probably come back with change in their kind of values once they've gone through the diet program. So we'll switch on to the workshop now, and if there are any questions, would love to answer it. Or should we go straight to the workshop? I know we're dealing with limitation. Samir, I think we should do yours first.
S1. Why is there so much of a difference? And what do we tell the patients? Number one question. Number two, many a times when we do ultrasound, we label as grade 1 or grade 2 fatty liver. And when we do the blood work, the SGOT, SGPT are on the level of 10s and 20s, which absolutely normal. So then they are saying, which is right? Is the blood work right or this is right?
Okay. So the second question is easier to answer. You know that if there is fat, it can yet not be NASH, and that's what I was trying to tell you all the time. So you will get OTPT affected only when there's NASH, not when there's steatosis. So steatosis, that is NAFL, non-alcoholic fatty liver, will only show alteration of liver functions when you have NASH. So that's really the first indicator that you've got. But it's, I'm telling you, with blood levels, there's a lot of false positive and false negative at times. So different labs, inter-observer, even different labs will have different ranges, cutoffs. So there's a lot of when did the sample be taken? Was it taken in fasting, not fasting? So we don't have control over that. But I have seen that if you've got blood levels which are very high, then this will show you that there is NAFL, NASH. So it will show you the values. At the same time, if your values are very high, that means you've got jaundice, acute hepatitis, then this will also show you slightly higher values. So we know that in presence of acute hepatitis, the values will come high, and you've got to repeat it once the hepatitis comes down. So if you've got fatty liver and you've got normal values, I think that's good, because that means you don't have a liver damage. But we must estimate that objectively with ultrasound. The first question was MRI versus ultrasound. Now, see, these are all new technologies. Now, we've got papers which have corroborated ultrasound with MRI at centers of excellence, showing a correlation of more than 90%. Area under the curve more than 9.3. I showed you those papers. So there is good correlation in centers of excellence. Now, different centers where we don't have control. So we are comparing A center MRI and B center ultrasound. So there's going to be a little bit of difference in comparison till the time that we establish. In fact, before we started this, I was talking to the GE people that let's actually do our own study and establish that what are the correlation between MRI and liver. So there are some papers which have done that, but we do need to do more on that. So there will definitely be some consensus when we actually establish that it works with correlation with MRI. At the moment, we are in a stage where we know it works because there are international papers, but we will have to prove it to you. So it's the standard ultrasound probe. That's the beauty of it. And you can see the patient's hand is outstretched. I'm not sure whether he's fasting, but generally speaking, we do it in fasting. So we always begin with ultrasound, and we look at the liver, the portal vein, the vessels, look for any mass. And the periportal fat here is not distinct. So you can see the diaphragm here. It is bright, the liver. And of course, compared to the kidney, it's really bright. So I would put this as grade 2 fatty liver. And I'm sure somebody else will think differently, and that's why ultrasound has inter-observer variability. But we can't see much of periportal echogenicity, so I suppose that would be a grade 2. And the advantage again is then you're actually looking at the liver, you're looking at the spleen, you're looking at the caudate lobe, you're looking at the blood vessels, none of which fibroscan can tell you. So you're looking at the direction of flow, and it is damn funny. I had a patient yesterday with Fibroscan was done with the hepatologist, and then it was sent to me, please do Doppler to look for direction of flow. So it's that, it's so basic that, I mean, they could have asked for a fibroscan with the ultrasonologist to look for the flow. So what they don't have, they will send you, but what they have, they'll think twice and they will say fibroscan is better. So immediately you're looking at the spleen, etc. And you know, so you've got a lot of information. Is there ascites? Is the surface smooth? And then you finally narrow down to doing your measurements, which doesn't take much time. And we select an area here in segment 5, 6, or any area here, 7. I think this is a good area. There's no blood vessel here. We will ask him to suspend respiration in expiration. हम बोलेंगे तो श्वास छोड़ के श्वास बंद करना है. श्वास ले लीजिए, छोड़ दीजिए और श्वास बंद करना है. So we then go on to this this UGAP button here, and we then target the segment 5, and you can see this myriad of colors here. Now in UGAP, unlike in shear wave, you can't move the ROI from up to down. It's only side to side, and that's what we really want. So we take a good segment, swans ban kar lo, and then freeze it. That's it. Or nothing more needs to be done. This yellow color here on this box tells us that this measurement is reliable. Otherwise, it will turn red. So there is a quality control that is inbuilt into the system, and you take multiple measurements in a linear fashion from side to side, and that's it. We are almost done, and you can see that the values are really high. So we go into the worksheet. The variation is not more than 5.9%, and your average value is 0.78. So he's got S3 stage steatosis, although the ultrasound is showing grade 2 fatty liver. And this we see all the time, that you've got a... so I've stopped believing in grades now. I think grades were not, really the way we should be doing fatty liver anymore. It's the grade of steatosis which is important. And so this is... And it's scientific because you're actually measuring the speed of attenuation in a liver which is altered either with fat or fibrosis or with stiffness. So when you measure the speed of something which is known, that this tissue is behaving accordingly with known phantoms, they have actually arrived at these values, it can be relied upon. So this is what we get from his then. At the same sitting, we have a preset for the shear wave here which magnifies the liver a bit. So you can see the liver in a much better way, and you can see the surface. And then we have here what is... Now I will do this in a wrong way first to show you how the machine is very accurate. Swans ban kar lijiye, swans ban. So I'm actually going on to... You look at the number of vessels there, and you will see that exactly at the site of the vessel. So first and foremost, you must get a homogeneous yellow in the box here. This is the quality control box. If it's homogeneously yellow, it tells us that the shear wave can be relied upon. This we didn't have before 2D shear wave came upon. Initially, we would just select an area free of vessel, free of mass, free of calcification. But now, even if there's something, the machine will tell you. So that's the area where you see there is a dropout. You're not going to get a shear wave activity out there. And so we cannot rely on it. So you take it from here somewhere, and it's about 1.47. But I'll take it in an area which is free of vessel now. And probably, so what we do generally, we take it 2 centimeters below the liver capsule in a perpendicular fashion. So we don't go oblique like this. We don't go oblique. We put the insonation is perpendicular, at least 2 centimeters below the liver capsule. Here you will get liver artifacts and reverberation artifact. So we'll try and do it there. Swans ban. You see that from the capsule you're getting reverberation artifact. So this will lead to false positive. Now, when you're doing fibroscan, you don't know where you're hitting actually. You could be hitting here, you could be hitting here, you could be hitting the gallbladder for all I know. So, and then you select a level there. Swans ban kar lijiye. And you see the perfect picture, perfectly homogeneously yellow, and telling us that the shear wave quality is good, and he's got high fat content, but he's got good shear wave velocities. And you can take multiple values because even biopsy, we take only one sample, or at the max 2 samples. But this, what we call as virtual biopsies, you can take as many as you like. You can even move to another area. Ideally, it's not recommended, but you can move to another area and take another swans band kar lijiye. So there's a good shear wave quality here. So we will take the final value here as 1.45. So it's the upper limit of normal with a variation of 4.5%, which is completely acceptable. Anything less than 15% is an acceptable value for variation. So he's got values slightly on the high side. He's got heavy fat load with upper limit normal shear wave velocities. From 2010 to now, I've been using shear wave and elastography, very convinced about its role in various parts, in musculoskeletal, small parts, especially breast. The good thing now is that this is the first machine that has got it on the prostate, shear wave on the prostate. So now we are doing all our prostate biopsies after doing shear wave, both strain and shear wave, and we are seeing definite correlation. Of course, we are looking at the MR PIRADS value, doing the shear wave, and then doing the biopsy. And to me, it sounds good, it looks good, but maybe next 2 years we'll see more numbers. So I think progressive liver disease is a temporal situation where people need to be monitored over a period of time. They need values to be known over a period of time, whether it's changing, whether what they're doing is improving, whether it's helping, are they doing the right thing, is the exercise program correct, is the diet program correct, and that's where our role comes in as preventative radiologists now of guiding the patients to manage this disease in a way that helps them participate in that whole process. So most times now we have patients coming up for follow-up, they just come back 6 months later, doc, my value was 0.80, or what is it today? So it's a tremendous benefit to them, and I think this technology is here to stay, will be there. It's like in 91, people used to ask, color Doppler, it's rubbish. And what's the role? Biophysical profile is as good. One very senior obstetric sonologist told me, why do you need color Doppler? Its biophysical profile is good. So I said, you might as well then not do ultrasound. You just examine, do fundal height. So after that, I saw him taking demos on Doppler after 5 years. So it takes time for technology to be accepted, and the technology is there. It's up to us how to use it. It's for our benefit, and I think I see it working, so I'm pretty convinced about it. And I've gone through all the stages of development of elastography, from strain to shear wave to 2D to UGAP, and I don't know what's in store, but what's new is the prostate, which is very exciting because we didn't have it in the transvaginal transducer. Now it's available with the linear, with the convex abdominal, and with the transvaginal transducer. So even ovary, etc., you can do. That's bound to be there. It's like, see, it's like, you do a blood report at Raptakos, they're using probably Delphia Express or some other machine, some other reagent. So different values are going to be different. So what people say is that just establish the range. Don't tell us what stage of fibrosis, tell us the value and we'll compare it on our own. So I think some kind of understanding has to come with the different manufacturers to establish a standard. Yeah, but I have seen two companies. Earlier I was using the Siemens, which is now shut down, and then now I've been using the GE, and the same patients are coming back now. They're coming back, and I think there's a pretty good correlation. Thank you very much.
Thank you, sir. Thank you so much for a detailed session on shear wave and UGAP, especially as you rightly said, shear wave has become complete comprehensive now. We have shear wave in linear, TV, as well as in convex. And thanks for explaining very well with a live patient and explaining the importance of UGAP diagnosis in the liver in a very early stage. Thank you so much. Thank you all for taking your time to attend this session. Thank you all.